toast. We'll get together, have a few laughs.
Friends listen to each other. They don't shoot each other. Do they, Audrey?
Thing like a traffic jam? Throwing a car at me? Gonna stop me, huh?
You cannot use your U.S. Air Force personnel-only drill time card. Who wrote this thing, by the way?
Tripped, slipped on the floor, and accidentally stuck your dick in my wife.
So, back to you, Stuttering John. How's everything in Poughkeepsie?
Houston, you have a problem. You see, I promised my little girl that I'd be coming home. Now, I don't know what you people are doing down there, but we got a hole to dig up here.
Still got it.
Still sexy.
Leela at Multipass. You know this Multipass. Leela Dallas, my wife. We're newlyweds.
Just met. You know how it is. Bump into each other, sparks happen. Yeah, she knows it's a multi-pass.
Yeah, anyway, we're in love.
Zed's dead, baby. Zed's dead.
Welcome to Knife Skills. My name is Dr. Rich Hilsden. Thank you once again for joining. As always, or at least always lately, we have the one and only Dr. Tommy Chan, Stanford trained neurologist. And this is a great topic, I think, for today. I know, Tommy, you were excited. It's hard to find the right emotions because I don't know about you. I've been a Bruce Willis fan for a very, very long time. Obviously a diehard fan, but probably one of my favorite movies that Bruce Willis is in is Pulp Fiction, without a doubt. And that's what we ended that clip with. So how are you tonight?
I'm good. How are you, Rich Hilsden?
I'm doing all right. Tommy, do you have a favorite Bruce Willis film?
Die Hard, because I used to play the PlayStation Die Hard game, and then so like that's obviously the classic one. And then recently I actually saw it on TV again. So
was Die Hard a Christmas movie then? Is that
exactly the reason I just watched it in December was because that's the debate, right? Is it a Christmas movie? And my answer is yes.
I think a lot of people enjoy that debate. It's fun. And I agree. I think, most of us watch it around Christmas time. Obviously, it's got a little different feel than a typical Hallmark Christmas movie, but we love Bruce Willis for that. Mm-hmm. So really what we want to do today is we want to talk a little bit about Bruce Willis's diagnosis of aphasia and really what that means and bring some awareness. Obviously, this is a terrible thing to happen to any individual, and it's a real condition that some of us may have to face or loved ones may have to face. And obviously, my heart goes out to Bruce Willis and his family finally, coming out publicly and really talking about the fact that he's had to leave the role of an actor because of aphasia. So we're going to go in and discuss a lot of those elements today. I want to encourage anybody who's watching. We have a few viewers right now live, as we always do. Feel free to ask any questions about this condition broadly that we're going to be talking about, and we'll be happy to answer any of those questions. In a minute or two, I'm going to show another clip of some of the news coverage of Bruce Willis's diagnosis of aphasia. But I want to just dive in and ask Tommy a couple questions right away so people understand. When Bruce Willis came out public, or his family came out publicly and described his condition as aphasia, what does that mean? I think a lot of people don't even know what the term aphasia actually even means. Like what is that phrase?
Yeah, first of all, why are all the celebrities having neurological problems, right? I think that it speaks to how neurological disorder is very common, especially with our aging population. There's a lot more neurological conditions or disorders we have to be aware of. Well, Rich, to answer your question, aphasia, it's a disorder of language, and I was a little bit surprised how they delivered the message in terms of he suffered a condition called aphasia.
Yeah, me too.
It's not really a condition. For example, if you have a headache, is that a condition or is that a symptom, right? So I
Right.
think that we can dive much deeper into what that actually means. But so it by definition, it means a disorder of language, and language can comes in the form of speaking, so fluency where we articulate our words, understanding, so me understanding you talking to me today, asking me questions, and obviously repeating words as well, naming, writing, and writing. So those are the components of all language.
Now, the word aphasia, like if we were to break it down, what does it actually mean? It's like absence of language. Is that sort of what the term aphasia
Yeah,
implies?
exactly. Anything that with that A, in the A alphabet A in front of a word in medicine often means that lack of, right? So there could be agrammatical, so that like lack of grammar or absence of grammar.
Yeah, it's an interesting concept too, because sometimes people have a hard time breaking down that idea of like, well, what's a diagnosis and what's a symptom, right? Sometimes we get focused on the symptom, and aphasia, as you're saying this here, is a symptom of something else. There really isn't a disease or condition called aphasia at all. Aphasia.
I will actually correct. It's a
Okay.
sign. It's a
Sign.
clinical
Okay.
sign.
Okay.
As you know, Rich, you know how symptoms is what the patient reports. Sign is
Right.
what we identified on exam, right? So a lot of medical students who are listening in, they'll be like, "Oh, that's like I remember, like I was taught about symptoms versus sign." So when a patient comes in with a language problem, they will not tell you, "Hey, Dr. Hilsden, I have aphasia." No, they don't say that, right?
Right.
They'll be like,
Right.
"I have trouble with speaking, talking," and then you examine them. You're like, this patient is demonstrating signs of aphasia.
Yeah, got you. And so it's basically how we describe as doctors what we're seeing. We're using that term to label, hey, oh, this is that type of behavior, for example. Yeah. Well, you know what? There's a question right away, and I think this is a bit earlier than we were going to get into this, but I do want to encourage our audience to ask questions. And so Lee said, can a stroke or other abrupt brain trauma lead to primary progressive aphasia, or is that limited to neurodegenerative diseases and tumors only? So that's an interesting, actually, that's a very sort of complex question. I think might require us to address a few things, later on. But I guess everybody, let's start with the beginning. Is a stroke, for example, a condition that can cause what doctors would describe as aphasia?
Yeah, that's a very high level, complex question Lee just asked, and I'm sure
Lee probably went to medical school or something. I don't know.
She's probably a neurologist. She's probably a neurologist asking this question and testing me. But that's actually a very good question. That question contains a lot of components that we'll talk about today. I think to simplify that question a little bit, can a stroke cause aphasia? In fact, that's one of the most common cause of aphasia, because when we have a stroke, people often say when you identify you couldn't move, couldn't talk, couldn't speak, you call 911. That could be a stroke.
That's right.
Stroke, right? So in that case, depending on where a stroke means that there is a lack of blood flow to a region, or there's a brain bleed, that means a stroke, to an area that's responsible for language, then someone could develop an acute onset of aphasia. So that to answer second part of the question, can something lead to something that's progressive? I'm not sure, Rich, you'll probably ask me this later. I don't want to go too far ahead, but I think Lee will address that second part of the question in a bit.
Yeah, I think so, because I think we want to get a little bit into what could be going on with Bruce Willis as far as the diagnosis a little bit further. You know what I want to do? I want to see if I can share, just for the audience once again, a little bit more. And let me just see if I can pull this out here. And I'm going to do my best here to see if we can share my screen and just show you one of the Instagram posts. This was the Instagram post from his ex-wife, Demi Moore. She's just a little easier to find than some other folks. But let's take a quick peek here. All right. Looks like we can see that right there. So, I'm just going to read it out if people can't actually see it. So it says, to Bruce's amazing supporters, as a family, we wanted to share that our beloved Bruce has been experiencing some health issues and recently been diagnosed with aphasia, which is impacting his cognitive abilities. As a result of this, and with much consideration, Bruce stepping away from this career that meant so much to him. This is a really challenging time for our family, and we are so appreciative of your continued love, compassion, and support. We're moving through this as a strong family unit and wanted to bring his fans in because we know how much he means to you as you do to him. As Bruce always says, live it up. And together we plan to do just that. Love, Emmy, Demi, Rumi, Scott, Mabel, and Evelyn. So I think that's wonderful to see the family supporting Bruce Willis here. And I really do feel that, in times like this, these are difficult times for any family. The support of someone who's suffering with a cognitive decline is so important. And we're doing this broadcast really just truly out of love of Bruce Willis and a love of medical science and trying to help people understand when a celebrity or something like that has a medical illness, so people can really have a less confusion, less misunderstanding of what's going on. So one thing that they brought up is they use the term diagnosed with aphasia. And we just talked a little bit how really aphasia is more of a sign, as we said, rather than a diagnosis. And I would say a decline in cognitive abilities would be a symptom or sign as well. And both of those would underline something else. So when you see aphasia, Tommy, and a general decline in cognitive abilities, does that help you sort of sort out the differential as opposed to, let's say, it was just isolated aphasia with otherwise normal intact cognitive function?
Yeah, I think that was something as similar to the previous I don't want to say episode, but like when we had our live sessions on Hailey Bieber's about, we tried to kind of guess and make a hypothesis or diagnosis based on what's available in media, right? So based on that Instagram post, when someone mentioned that they have features of any sort of language problems plus cognitive issues, is right off the bat, it tells me that this probably is related to something that is progressive and something that's under neurodegeneration. So Lee brought that up. She mentioned something called primary progressive aphasia. So that's PPA. It's one of the subtypes of of a neurodegeneration disorder. So that was the first, because that was the first post I saw as well, because that was the first Instagram post, and that was also posted in the news and all that. So immediately I was thinking, okay, so what kind of condition can cause that? So I have my own hypothesis, but I don't want to review it yet unless Rich.
Well, we're gonna get into that. Let's not reveal that either, for sure. But one of the hypotheses, though, that have come out, and I'm curious to see what you think here, and we've seen some media speculate this, is, could he have had head injuries, for example, if he was doing his own stunts or that kind of thing? Could multiple head injuries potentially be a contributing factor to this potential diagnosis of aphasia? Do you have any thoughts on that, just as a gut feeling?
Yeah, let's take a step back. What are the most common causes of aphasia? That includes stroke, space-occupying lesion, including tumor infection. And one of the big categories is neurodegeneration, as we talked about. But when we say neurodegeneration, it could be something that is just genetic or spontaneous, or there's a theory that people could develop neurodegeneration from a condition such as chronic traumatic encephalopathy, like in the movie of Concussion, or people who have repeated head trauma, which, because in the pathology,
Will Smith is, of course, the lead in that movie.
Yeah, with that big slap, I'm sure
that's right.
That's
right. Chris Rock might be suffering some CTE potentially in the future after being smacked in the Oscars.
he needs to repeat the slap, though.
Yeah, it's true. It's never just one slap that causes CTE, for sure. Although it does make me wonder. I've seen those. I don't know if you've seen this trend, at least on Instagram or YouTube or whatever, of these like slapping contests. It strikes me that that's just asking for like long-term neurological problems.
Oh, 100%. I think I asked you this a couple of weeks ago. I'm like, how is this a sport? And we might see more pathology in 10, 20 years down the line for these people.
Well, and there's a really good question. I mean, how long have we known or suspected? I'm just going to show another picture from Demi Moore's Instagram here while we're chatting. How long have we known or suspected that repeat head injuries could cause something like a cognitive decline? Because to me, it seems obvious, and yet, like the movie Concussion talked about, it really showed that it wasn't actually that obvious, or at least there was some denial happening. What's your understanding of that relationship?
I think nobody can put a number on or specifically on head injuries and the outcome from this. I think there's a lot of components come into play. I honestly do not think that as an actor, Bruce Willis, even let's say someone who's a stuntman, would suffer enough injuries to really cause such a severe encephalopathy, meaning that like traumatic degeneration to the brain that can cause a significant pathology.
Right.
Against everybody has different threshold, right? So like people, if they're genetically more inclined to develop something, maybe sometimes you need less of an injury or less of a duration to have that outcome. So it's hard to say. But as an actor, I know Bruce does a lot of action films, but he also have stunt doubles. I don't think he does every single thing by himself for the past 30, 40 years.
Yeah, and that's a great point. I think one thing that I think actually the evidence from NFL football players tells us is that this is a unique sport where there are multiple repeated subclinical head injuries, and that it doesn't quite manifest the same in other athletic events, although I know there is concern about that with professional soccer players. There's concern about that with hockey players, for example. But there are many sports that do put people at risk of concussions and don't have that same risk of CTE, or we're not seeing that same signal. So I do think there is a difference to that, again, repeated multiple low-level head injuries. Certainly I've had some experience in certain environments where people do get those repeated concussions, and they can have long-term symptoms, but again, not necessarily to the level again of those brain changes with CTE. Okay. So now is the cognitive decline with CTE different in any way from, let's say, Alzheimer's, for example? And I just want to ask you another question related to that. So that's question. I'm going to bury another question in there. Is Alzheimer's the most common cause of dementia, or am I thinking it may be another cause?
Yeah, no, that's a very good question. So obviously, neurodegeneration is a huge topic, basically the entire subspecialty of cognitive neurology. And Alzheimer's is one of the most common causes of dementia, so cognitive decline. And people who have, for example, to distinguish between the you mentioned about CT, you mentioned a few terms there. Okay, let's take a step back, think about what kind of dementia could somebody get from CTE. Okay, let's talk about that. Meaning like repeated head injuries, and then there's a pathology where it comes up. A lot of times, it's very similar to what the movie portrays. These people start to develop personality change. Disinhibition. We call that a frontotemporal lobe kind of dysfunction, because our frontal lobe in the front here is responsible for a lot of executive functioning, planning, inhibition, kind of how we kind of be human, doing things like human. So when that's impaired, these people might have a lot of different behaviors that could be seen. And that's something that was actually portrayed in the movie, right? These athletes became very agitated, very, very angry. They're not themselves anymore. On the other side, Alzheimer's is predominantly affecting brain region that involves for memory, so the temporal lobe.
Okay.
And with the temporal lobe, that's why people start to complain, hey, like their partners or carers will ask, why they don't remember these things? Why are they asking me the question again? The tricky part about aphasia in those two contexts is that language, the language center can also be found in the frontal and the temporal lobe. Those are the two main regions of the language centers anyway. So when people have injuries to those areas, not only could you have just isolated language problem, aphasia, or they could actually have other symptoms or signs. And that's how we put the puzzle together, right? That's That's what makes neurology interesting, Rich. You know how like we want to localize the lesion.
That's right. Yeah, we always joke about that.
How are we gonna localize? How am I gonna know exactly which part of the brain is coming from? Okay, tell me more. Tell me more symptoms and signs.
Yeah, the more you know, the easier it is for you to kind of figure out where it's coming from, for sure. So would you say that with Alzheimer's, as opposed to other types of dementia, personality changes are maybe a late sign or less frequently noticed than maybe memory, as opposed to, we talk about sort of frontal dementias, might be slightly different underlying pathology, tend to present with a lot of personality changes. Is that correct?
Exactly. I think that eventually anything that is long enough, or the degeneration it's long enough, they overlap. There's a lot of overlaps between all these conditions we talk about, but it's usually in the beginning how you can actually discern between these conditions, but they all converge at one point. Let's say if somebody has some sort of dementia for 10, 20, 30 years, it becomes very difficult to see if that's the time, a point in time you meet them. But that's why it's important to take that history. What happened 10 years ago?
What
was there
happened
any
first?
clues 20 years ago, right? Like, was there any signs coming on board already?
So would you say that when it comes to dementia, there's almost different paths to the same end outcome? Would you say that as you get to later and later stages of dementia, really all forms, we could talk about, and I would like you to discuss a bit more of the causes, vascular dementias, again, versus Alzheimer's, versus we talked about traumatic causes. At the end stage, very many people have difficulty with their activities of daily living, appetite, weight loss, those type of things. Do you find that there's multiple roads that lead to that same unfortunate ultimate outcome?
Yeah, I guess in some ways, yes, but a lot of times people suffer complication along the way, or they have other issues that arise. For example, a lot of people with the frontal aspect I was telling you about would commit suicide, for example. So a lot in the movies you saw in Concussion, for example, a lot of those, there were a lot of suicide attempt, and people felt like, oh, they were very depressed and then they commit suicide. But there's another part to that story, right? For Alzheimer's, again, maybe this turns out to that they end up requires a lot of care. They end up in a retirement nursing home. So we really do not really see like the end. So to answer your question, if we were to compare 2-3 people with different causes or localization of their dementia, would eventually they all lead to the same point at the very, very end point? Obviously, there's a lot of variables. In theory, they could.
Yeah. Yeah. And I mean, I want to ask you another question about that. Again, the CTE issue with the suicides, is that largely because there's a bit of a disinhibition? Is that correct? Like they're depressed or feeling down, the frontal lobe would normally stop them maybe from behaving in a certain way, and then all of a sudden they're able to act out on that. Is that fair to say, or am I mistaken on that?
That's one component, I believe. The huge component is there's a huge region. I always say this: the brain and the mind is the same organ. So when there's any types of injury on a neurochemical level, there's going to be disruption of all the serotonin, dopamines, and adrenaline, where there are centers in those brain regions are responsible for that. So when that circuitry is disrupted, that's also overlaps with what people suffer from psychosis, depression. Is actually there's a lot of overlap in these pathways, which people could develop just by what they experience in life and genetics, or from injuries. Yeah,
they may be more genetically prone to that type of mood disorder, and then all of a sudden you're adding a dementia element on top of that, and then that uncovers something, or there's an emergent property happening with that dementia. Let's bring it back to Bruce Willis for a second. I'm gonna share a little quick clip here. This is from his Instagram, and there's not gonna be enough for you to make a diagnosis here, but this is about a year ago, and you'll notice in a 16-second clip a few signs of cognitive impairment, I think it's worthwhile just to pay attention to it, educate people, and I can comment a little bit from my own experience. I'll share in a few minutes about this. So let me just pull this up here, see if this works. Okay, so I'm gonna have to.
Hi, folks. This is. Sorry. Hi, folks. This is. Sorry.
All right. So I don't know if you picked that up there, Tommy, really quick there. So very short clip. And he said, "Hi, folks. This is," and he actually had a hard time. I think he was trying to say his name there, and then laughed it off. And the comment here is Bruce Willis still making himself laugh and those kind of things. And there's a little bit to actually unpack there. First of all, I just wanted to get your gut feeling on that very short 16-second clip, and understand why we have so little from Bruce Willis at this stage in his life. Anyway, just want to get your thoughts on that clip really quick.
Yeah, I think I'm sure you're going to show a little bit more clips as we can put the puzzle together. That when in that video, what it shows is he has some word finding difficulties. So
Definitely.
that's the kind of he was trying to say something, but then he wasn't able to kind of say it. And also there it's a little bit slow to articulate, and obviously there could be other clips that also demonstrate that. And again, that helps us point towards one subtype of dementia more than others.
Yeah. So, I mean, again, it'd be nice to have a bit more, but I certainly don't blame him and the family for wanting as much privacy at this stage, because, the Bruce Willis's characters were so larger than life, so strong, you couldn't kill him. You could never beat the Bruce Willis character, right? He always came out on top, and seeing, the actor struggling, comparing that to the characters is difficult. So, that clip was nice to see, because I could see that humanity in him. I could see a little bit of what he was struggling right there, in that relatively recent clip where, even trying to get that simple sentence out was turning out to be a bit of a difficulty for him, for sure. Well, Tommy, why don't we take a little look at another video here? This is a little bit longer, and it's an interview, and I'll just fast forward to some midpoints. And we may not be able to make any diagnosis here, but this is about 7 or 8 years ago, and it was noted at the time of being a bit of a cringe-worthy interview, is what they called it, or it was an interview that caused some controversy. And I actually do believe that there was maybe some underlying cognitive impairment happening here, and you could see some strategies of him dealing with it throughout the interview. And so maybe we'll just watch it together for a few minutes just to get a sense. Let me pull it up here.
Good, Jamie. A lot of pressure is on you right now, bud. And you're on camera?
Okay.
Just take your time.
I'm Jamie Edwards. It is Magic at the Movies. Real pleasure to welcome Bruce Willis, Mary Louise Parker. Hello.
Hi.
So good to see you guys, and welcome back to London. Because of course you did film some of Red 2 here.
Most of it. Sorry.
What was your favourite place to actually film in? Because you do travel all over the world in this film.
Istanbul.
Why did you go to Istanbul?
Oh, not in this film. I thought you just were saying my
In
favorite.
general.
In general, I like Istanbul. I think it's a pretty cool place to go.
At least it proves I've seen the film, which is a good thing.
Yeah.
Has any actor ever told you this, Jamie? This part is not acting, what we're doing right now. You might be. But we're just selling the film now. Sales. The fun part was making the movie.
The fun part happened, yeah.
So how would you sell me the film then? What would you say that is
I
the
wouldn't.
best part about the film?
I would slash my hooves.
No, I love this film.
Oh, yeah.
I think it's an amazing
look, bro.
cast.
It has, I do feel like we're about to break into song. I think people say that it has, having not seen it, but that it has a little bit of everything. It has romance, action, comedy, so it's...
Recipes. Fashion tips.
There are some fashion tips actually
Aerobics.
in Paris. That must have been pretty nice to go over to Paris.
It was nice to, because usually I shoot in like Philly or something. Nothing against Philadelphia, but I never got to shoot in Paris before. That was pretty cool.
One of my favourite lines in the film comes from John Malkovich, and he's giving advice on how to look after women, how to keep them happy. And I'm going to say it because I think it's a cracking line, and it's rent Dirty Dancing and tell them you love them. As you are a god to all women, tell me that is the way to keep your women happy.
No.
All right, I think I'm gonna just pause that there. I think we've got enough of that interview to kind of get a sense here. So, I look at it a few ways here, and I'll get your thoughts on this, Tommy, as well. One of the things I've noticed is it's a confusing interview to watch. And if you looked at some older stuff, you would have seen that Bruce Willis was much more engaged, and his responses made more sense. This was actually one of his very last public interviews he did promoting a film, and I think it was one of the last because there was an element of there's certainly some confusion going on that. And what's your initial thoughts seeing that? Again, it's about 6-7 years ago at least.
Yeah, I also saw this clip after I saw the Instagram post, and I think this clip really demonstrate like his deficits.
Yeah,
because he clearly have a few deficits that I could identify as a neurologist. Is that he have trouble understanding questions. But it's a little more complex question because he was able to, for example, he asked about the travel and then he mentioned Istanbul, and then he said, "Oh, I thought just my favorite place."
Right.
Also,
yeah, exactly.
So he was still able to kind of get parts of it, but not really. And again, his speech is pretty slow. He's still very articulate. Pronunciation is still good. These words are still right words.
Right.
But he's having really troubles to find the right one though to say. And hence he often even use sales, for example, on selling and
Right.
as a clue. And that really tells me that he still understand the meanings of these words. The speech is still fluent, but during maybe small talks or conversation, you might not be able to pick it up. But when it's things a little bit more difficult, higher level, such as an interview, that becomes more apparent.
Yeah, and you have to understand, I mean, that's a task that a lot of us would struggle with for sure. But if you're an actor, you're a trained communicator, you're an expert at communicating, and you're functioning at this very high level. And what's coming out there is, a challenging environment is pushing the limits of how he's able to cope and how he's able to, I would say, even cover up the cognitive impairment, aphasia issue that he was struggling with at that time. In a simpler environment, if he was saying going to a restaurant or something like that and ordering or doing those regular tasks, I suspect he would have had a much easier time with that, would have been able to cope with a lot easier because the complexity, the dynamics were less than in that type of interview.
Mm-hmm. I would actually think if the interviewer were to ask Bruce to repeat few sentences, he would have troubles doing that.
Interesting.
So his deficits of repetition could be pretty prominent as part of his deficit. Obviously, that's something that you do normally formal testing. You won't just say, "Hey, Rich, can you repeat the following after me?"
Right. Well, here's actually a good question for you. Why don't we ask a little more about that? So let's say you have someone who's presenting, let's say Bruce Willis's family is starting to express concerns at this stage in his career and says, let's find a neurologist who's got an expertise in cognitive impairment and do some testing. What would be some of the first tools that might be used to sort out what was going on there, trying to determine, is there actually a cognitive impairment or not? What would be a simple way?
Yeah, so let's go back to the basics so that because our listeners could understand. So just goes back to the fundamental of a neurological assessment. How do we test language? Well, first of all, when you talk to them, you already can appreciate are they fluent or not, right? Like they can speak the words that are coming out their mouth. Secondly, can they follow your instruction, meaning understanding your commands? So, for example, we often ask, can you close your eyes and stick out your tongue? Well, that is instructions to follow. Next
Right.
thing is like start showing them some objects because I'll be like showing them my glasses, my pen, and ask them to name it. I'll ask them to write some words out and then read it afterward. And then lastly, I'm gonna ask you, hey, I'm gonna say a phrase and please repeat it after me. So a lot of times we say no ifs, ands, or buts. It's the textbook teaching. But
Right.
sometimes you can go as simple as, can you just repeat the sentence, the sky is blue? If they cannot even do that, you go easier. You say, repeat basketball. So by just doing that, it probably took me less than 20 seconds. And I already probably tested the 6 main domains of language, as we previously talked about in the beginning of the show. So I'm sure he has already been assessed by neurologists and those tests have been done. But next level, there's a lot of very, very specific testing to tease out different language deficits. In a lot of times they come into different sentence structure that has been developed, that has increased yield of the diagnosis. Those are next level things. So not for
for sure. I mean, one of the
session, but
things
yeah.
they taught you in medical school. The classic one is draw a clock, which is kind of a pretty a fancy way to do it. I guess. I don't know what your thoughts are on the clock drawing. Do we still use drawing the clock?
Well, you know what? You brought up a good point. I'm sure a lot of listeners here who, if they're in the medical field, they have heard of the Montreal cognitive assessment test called the MOCA, not drinking a mocha, but like MOCA. It's basically testing different domains of cognition. So what you mentioned about drawing a clock is like, hey, draw the clock, put all the numbers in, show me it's 10 past 11. So that it's really to demonstrate if a person has any visual spatial deficit or not, because you need to be able to see what's in front of you to draw that. Not really language though, not aphasia though, but it could be a part of another sign actually of dementia.
Yeah, I'll just pull this one up here. There we go. So can you kind of tell us a little bit? So these are some examples of some clocks. Can you tell me here what some of these different clocks would represent, maybe as far as indicator?
Yeah, again, which is very like higher level things, but let's just give an example of the middle one, like the clock where all the numbers were drawn in the right side.
Right here,
you can probably say that, you know what, this patient might have issues of ignoring the left side of the road or left side of the room because all the numbers are filled out on the right side.
Right.
Similar to, let's say, like the clock on the bottom right. Is something that sometimes, let's say, people who have injuries to the right side of the brain starts to ignore things in the left side of the road. And that's kind of some features you can pick up from a visual spatial deficit point of view. And obviously there's different ones that are more, again, a higher level, that people sometimes look at the clock, plus a little drawing, plus how they draw a trail, plus what kind of words they write down, and put that puzzle together.
Yeah, those are those, and I guess the term they use for that is neglect, if I understand that.
Oh, yes.
Correctly.
Ding, ding, ding. 10
yeah. Well, you know, I went to med school. I know some of the terms, even though I'm not a neurologist. I can pull them out every once in a while. Perfect. Let's pull up one more video here, if I can do that. I think that might be useful because we talked a little bit about some of the news coverage. And so why don't we share that with our audience here real quick? Let's see what you're thinking.
Down to the coast. We'll get together, have a few laughs.
As one of Hollywood's top action heroes, Bruce Willis never backed down on the big screen. Now the star is facing a real-life challenge. His family says Willis will be stepping away from his acting career after he developed the brain disorder aphasia. While it's not known when the actor was diagnosed, crew members from recent productions tell the LA Times he showed signs of cognitive decline. Director Mike Burns worked with Willis on multiple films and says he noticed something may have been wrong after a 12-hour shoot day in 2020.
He was tired, and I can see that there was also some cognitive issues going on, and I, was concerned at that point.
Several sources told the LA Times Willis struggled with his memory and was fed lines through an earpiece, or so-called earwig on sets. The device Burns told us Willis used to assist with dialogue on a film they shot in October. This clip from the 2021 film American Siege also appears to show the actor wearing a small earpiece.
I wouldn't go there.
But the production company did not return our requests for comment. Willis is not Hollywood's first star to be diagnosed with aphasia, which can affect a person's ability to speak and understand language.
All right, let's pause it there. So what's your thoughts on some of these tools here that they're using, or he may have used to kind of help deal with some of the underlying aphasia symptoms that he was having?
Oh yeah, so that clip, after I watched that clip, that's the giveaway. Like that is, I'm like, okay, that I know.
So what is it about that clip? What was the what specific detail did you clue in when you saw that?
So some of the key words, right? So memory problem, number 1. 2, he has issues with requiring an earpiece. So that's very important information. The reason behind that is because obviously on sets, there's a lot of things going on, and it's very hard to focus on the things you want to listen to, but that will allow you to, that's what the earpiece is for. So it kind of helps you with what you're hearing. And that tells me that there's not that many aphasia, at least condition, that have significant memory impairment and also have issues of, let's say, like what I was telling you before, when there is a lot of things happening or more complex instructions are coming in or more surrounding stimuli, you're not able to comprehend that. And also there might be errors of things coming in. You might have a phonological error of like maybe not hearing what's right. And also with what we call auditory hearing, short-term memory deficit. So that really tells us a lot about that this is could be early signs of what people see in Alzheimer's, for example. And I'm going to review this. There's a very subtype of primary progressive aphasia called logopenic. So that's called logopenic variant primary progressive aphasia. And there is a lot of association with this condition with development later stage to the full-blown Alzheimer's disease. And the underlying pathology, let's say if you do pathology in the brain, you still see overlapping between that.
Yeah, I guess what do they say, amyloid deposits? Is that what it's called?
Exactly.
So, Alzheimer's. Yeah. And so you're saying this form of primary progressive aphasia is essentially a form of Alzheimer's, like a subtype.
Yeah, in simple terms, that is the case because there is different. I want to say variants of Alzheimer's. Again, it gets really complicated. Everything, there's variants and subtypes and subtypes. And then one of the subtype, as I say, that people with Alzheimer's could have different early on presentation. And that goes back to your first point. Do all these people end up at the same time point of convergence? Let's say all these Alzheimer's pathology with amyloid deposit patients, they might initially have the aphasia predominant. Some people might have visual, like sometimes people might have memory, but do they all end up having a little flavor of everything? And if you eliminate all confounding factors, the answer is most likely yes. So this is probably an early or a presentation, I would say, of the Alzheimer's disease.
And you think, what was again that subtype that you thought he might have? And your feeling here is largely due to needing more concrete auditory inputs to help understand language. Is that correct?
Yeah. So it's called logopenic, and sometimes people call it a progressive fluent aphasia. Well, exactly what it means is progressive. It's fluent. Bruce Willis is fluent in the words that's coming out his mouth, right? Yep. And the predominant, quickly summarized for the listeners here, is word finding difficulty, check mark, right? Speech is fluent. It is. Usually it's fluent during small talk, but when it gets a bit more complex, they might be a bit more slow, pauses, stops to search for the word that they want to say. And they could have that flavor of memory disturbance. And seems like that's the common theme of every videos or post that you have done today, Rich. That is one of the key words. There's some memory component. They're not saying, as opposed to the other types of primary progressive aphasia that usually affects behavior, they're not saying, oh, Bruce is acting erratically right now. Or he is like impulsive gambling and doing things that people would do. Again, going back to like let's say people watch a concussion movie, he's not acting like one of those patients with CTE, which the underlying pathology also overlaps with other variants of progressive aphasia.
So I want to actually move on to some questions here momentarily, but I do have one more question.
Yep.
And that is, are there any useful treatments for dementia? Anything that can slow the progression down, possibly reverse some of the symptoms? If somebody gets diagnosed with dementia, what are some of the things that can be done potentially to help out?
Well, great question, right? There's not that many things in the world of neurology that you could really treat and
Right,
cure. And
unfortunately.
that's something that deters people. But I want to emphasize that sometimes having an answer for the patient and family means a lot already, because then you can start to have planning. So for Bruce, he decides, or family and him decide that, you know what, I need to step away from acting, right? And it's something that can be probably been planning for quite some years, right?
No
If
doubt,
this is something that's neurodegeneration, and he realized, you know what, I've reached my threshold. So I think that part we have to understand about having a diagnosis helps future planning. Number one, is there any particular medication specifically for reversing dementia? The answer is no. There's no drug to. Is there anything you can slow down dementia? The answer is yes. There are different ways, including the actually lifestyle measures. Probably people do not want to hear that, like exercise, diet, good routine, avoiding
not smoking
behaviors that could cause further injuries to the brain. I know a little tangent here. There will be more studies coming out where people with chronic alcohol use, there's going to be brain regions that become smaller, right? That if you already have underlying conditions, for example, that makes you prone for any issues neurologically, that could be a tipping point, right? So I think that's important. I think there are medication, though, for example, for Alzheimer's that helps slows down the progress. Okay, again, it doesn't reverse it. And again, I think this is beyond the scope of this talk today about like which medication, what's the mechanism, and pharmacology. That's a separate topic, and I'm happy to answer them separately. But having allied health team is very important. So Lee, who asked the first question, she says she's studying speech science, if I recall.
That's
so
right.
I believe that might be a path down speech language pathology, so SLP. Huge. Me as a neurologist, who are my best friends? Nurses, physical therapists, occupational therapists, and speech language pathologists, and psychiatrists, actually, and psychologists. These people all play a significant role to ensure that when people are diagnosed with a condition like, let's say, this aphasia, progressive aphasia, they could have ways they can live their life. Let that be devices, let's say the earpiece, to allow him to be more functional. Ways to train how he could articulate words if that is his major problem, or how he can work in an environment where there could be a lot of stimuli, and a lot of times maybe lip reading. So a lot of things could be trained non-medication way to help them. And then it's a multidisciplinary treatment model. Again, like if there are new medication coming up for in the world of dementia, but is there anything that reverse it? We're not there yet.
Let's go to some questions here. So we have Ali Syed here, who says, if there's time, what's some of the pharmacology and mechanism action for these drugs you mentioned? Since this is a specific question, I know we're going into some detail. We want to keep this as much accessible to the lay audience, of course. But Tommy, why don't you give a quick shot at that question?
Yeah, so to kind of just trying to answer this question, like in general format, is that medication traditionally used for Alzheimer's is to ensure there's enough acetylcholine in your brain. So all these medications kind of work in terms of called acetylcholine esterase inhibitor. So you're trying to stop an enzyme from breaking down the acetylcholine. Okay. There are also other medications that may have other mechanism working at the glutamate level. Again, this is very high level things too.
Yeah, these are all different.
Yeah.
These are just like names for chemicals in the brain. Essentially, is all we're doing here.
You exactly.
It might as well be like engine oil or something like that. I mean, that's all we're talking about. These are essentially just terms scientists have used it, and of course they've got long names because we think we're smart.
Mm-hmm.
Yeah. So basically, you're trying to upgrade that acetylcholine or upregulate, I guess, make more of it available in most treatments for Alzheimer's, if that's correct. But does that improve symptoms? But does it have an impact on progression of the disease in any way, or no?
It slows down the progression. But in fact, actually, quite recently this year, it was a big milestone for the Alzheimer's world. Actually, I'm sure some people probably read it on the news. It's so big. It's I won't say the name of the drug, but then basically it actually works at the pathology level. So we know how we were talking about the amyloid plaques.
That's right. Yeah.
So there have been monoclonal antibodies developed or available now this year that actually helps target these plaques. So
Really?
we're in a road right now in medical science where monoclonal antibodies, it's kind of the new thing, new kid on the block, and you see that in migraine treatment, which I do, but now you also see it in treatment of Alzheimer's. So they are thinking that this is something that could potentially quote unquote be used for people with mild cognitive impairment or early dementia, and that they could help remove these plaques.
Some of the audience members may actually remember that monoclonal antibodies were one of the first targeted treatments for COVID, and they developed monoclonal antibodies against the spike protein as a treatment. So you'll see, again, this is a tool that people are reaching for quite frequently as a new way of treating a lot of medical conditions. And as you mentioned, migraine is one of them. Let me pull up another question here. This one's maybe totally off topic, but specific to you, Tommy, here. And it's, have you ever heard of global glial? I think they meant to say atrophy or autopathy here. Or maybe I'm wrong with the tauopathy.
Oh, tauopathy. So,
yeah.
So tauopathy kind of, again, these are going to higher level of the pathology level, okay? Because a lot of times when we diagnose people with dementia, we obviously talk about, today's session, we talked about a lot of the clinical features and watch all the videos, and could it be memory, first language, personality, etc. And then when you do look at, let's say, if you do get a biopsy or you get the tissue of the brain after a patient passed away, if there's features of, let's say, tauopathy, is a big thing. It's basically what you see under the microscope. With gliotauopathy, it points towards, you know what, this is the variant of, let's say, some examples of the frontotemporal lobe degeneration we talked about, or back in the days it's called frontotemporal lobe dementia. So it helps us kind of, that is like the final answer, the biggest review of, okay, all along you have told the patient has this, and then their clinical features are fitting with this, their exam fits this. One day when a patient passed away, now you do pathology, and that's the answer. You open it, like what you see in this, if it's tauopathy, then you're like, haha, everything fits, everything I was identified clinically was all correct.
But it's not something you can diagnose or be with certainty prior to actually doing an autopsy. Is that correct?
Yeah. Using that word, that globular gliotauopathy, it's a pathology terminology.
And there's no brain biopsies or anything that you could do to
So here's the question. Would someone go for brain biopsy just to make one diagnosis, knowing that there's no treatment for?
Well, that's right. That's quite the intervention, I would say, if it doesn't lead to treatments, for sure. Yeah. Let's go to another question. This is a bit simpler, and we've covered it a little bit, but I think it might be worthwhile to address it directly. And actually reminded me, Tommy, we were just recently in Miami, you, myself, and another friend of ours, Eric, and you and Eric had an argument about the genetic versus environmental factors when it came to hair loss, which I thought was quite funny. And you pointed out, you're like, there's always an environmental factor and there's always a genetic factor. It's never 100%. And so that'll answer that question a little bit. I mean, there's going to be environmental factors and there's going to be genetic factors. But I am curious when it comes to Alzheimer's or the more common types of dementia, what would you say the relationship is between the environment? How much can we do to improve our environment to reduce the risk of developing dementia down the road?
There have been some studies actually look at, like, again, we're going back to the the common sense stuff, right? Like physical activity, not smoking, light, moderate alcohol consumption, and a good diet, right? Mediterranean diet and cognitive kind of exercise and activities, right? And those actually can lower risk of dementia. And there have been some studies, again, obviously every studies have their confounding factors and limitation, even up to kind of 60%. That's a very high number. And I think that just like any medical condition, there's always a huge, if you have a huge genetic burden, there are, not the purpose of this talk, there are, for example, let's say Alzheimer's again, there are a few genes that put you at ridiculously high rate that you have like 90% chance of having dementia by the age of 60, 70, or 80, right? Then you're like, oh my goodness, I am fighting against genetic this whole my whole life. So you know that, okay, versus somebody who doesn't have that specific gene, then maybe they have just some family history. Then you know that, you know what, maybe that I there's a lot I could do with my life that I could combat that. The trouble here's the following. There's no calculation that I can say, hey, if you do this, your risk will guarantee be minimized by 50%, right? Studies are for your reference. But I always ask my patients or tell them, like, well, now you just have more reasons to live a healthy lifestyle. I know it sounds very like cliche. Like now you just have an additional reason. If you know that you have a family history of some sort or genetic burden, similar to hair loss, right? I'm sure there are a lot of lifestyle things that one could do to minimize or prevent or slow down at least hair loss, for example. I know it's a little off topic, but we were just talking about that.
Yeah, right, exactly.
Yeah, but hair loss a little bit easier to treat because there are surgeries for that. But again, we don't have brain transplant yet.
No, unfortunately, there aren't a lot of great brain-directed treatments. And as a general surgeon, I do sort of sometimes tease the neurosurgeons that they're doing a lot of palliative surgery in a lot of cases, right? They don't have an opportunity to cure as much as we do in general surgery. Well, there are a few more questions here. This one's off topic from our topic, but a little bit about you and me, and I'll just pull it up here. So this question for Dr. Chan. In neurology, my preceptor was telling me that each have ultra specialized conditions that you treat. Some neurologists are only headache, and then it goes on here to say some only seizures. Why do you think this is? Because other specialties like general surgery, you won't see a surgeon that focuses only on appendicitis or only on gallstones. Although I will say my practice is pretty focused on a few things. I'm a trauma surgeon, although that's pretty broad, but my elective practice, heavily hernias and gallbladders. So I do have my area of subspecialty, but when I practice general surgery, I do focus on a few specific things. What's your answer to that? And of course, you, as many of our audience members know, are a Stanford trained headache neurologist, but of course you do, stroke neurology and general neurology as well.
Yeah, no, Ali, I think that's a great question, right? I think that we are very advanced in medical science now, and particularly in physician training, that the more research we have, the more treatment options out there, it starts to become that we become more people become subspecializing. So, for example, neurology used back in the days, even in UK or Australia, is still a subspecialty of just internal medicine. But in North America, neurology, it's its own program to begin with. And I think I can speak of neurologies because, like I was saying, that because of the aging population, we're going to see more people with stroke, degeneration of the brain, injury that could cause people to have a lot of the symptoms you talk about, stroke, seizure, headaches, for example. And there's only so many neurologists out there. And then people start to develop research interest to get, let's say, promoted academically or get a job in different areas, what we call, AKA, find a niche. So that's how people kind of go into subspecializing in these different areas. It's not like they don't know how to be a neurologist or a general surgeon that removes appendix, gallbladder, or for me to manage stroke, epilepsy. But it also depends where you are, right? If you're going to be at Stanford, Mayo, Cleveland Clinic, you're going to have the niche of the niche, right? You're going to have people who not only just look at the headaches, but they look at headaches, but only migraine. Or they could be looking at headache, but only people who suffer head injuries, headaches. Or epilepsy, people who are only refractory to medication, or people who only deal with surgery. The list goes on. And I'm sure, Rich, you attest to that. That depends where you go. Like, things can become very specialized.
Yeah, it really does. I mean, we are academic specialists for sure at a fairly large academic institution, but we're not the kind of institution that's attracting patients from all over the world to deal with very specific problems. And so, as a result, even in my hospital, most of us are practicing the general part of our field in addition to our particular area of interest and focus. But I do think from a career perspective, and I know we have a lot of medical students who watch, and we love to provide advice. It is important to have an area that excites you that you want to focus your research on. And that can be hard to identify sometimes. And maybe for someone that's going to be a specific type of headache, like you mentioned, maybe it's post-concussive headache and that's your focus. Although you'll see headache patients of all types, you'll have a population that you're even more interested in, that maybe you do research on, that you have, that you're members of the community, that you educate in. Those are all great things, but to narrow yourself completely away from the general parts of your field, I think is probably not the best. I think most of us should continue to practice our full scope for the most part, but find that special area of focus. Again, if you want to be an academic physician, that would be my advice there.
Mm-hmm.
Well, let's do one last question here because we're going on to an hour. Lee's been with us the whole show today, and really appreciate your comments here. So here's a fairly long question here, but I'll read it out loud. Why would a person who lost all ability to speak and write and all language output was gone but could still gesture? Can you explain why he might be able to output this type of communication? This is actually kind of interesting because my understanding is that with most expressive aphasias, and you can correct me if this is wrong, and we actually haven't talked about the idea of a receptive aphasia versus an expressive aphasia, and maybe you can explain that for us. But my understanding that most expressive aphasias will impact both speech, writing, and again, gesturing type of communication. They really do have a hard time using any tools to express their intent.
I think when people have such significant injury to the brain, let's say stroke is a very common cause where, let's say, half of your brain is wiped out, okay, from break blood clot. Although that you might think that it only affects the language center, that because you're examining this patient that they could not understand what you're saying and they could not fluently articulate some words out. But there are other centers that are responsible for connecting all these things. So there are some deficits that you might see from a patient that's not very good in terms of localization, because it's not just coming from one brain. So even if you might encounter patients who, exactly what Lee said, like have that losing all speech or language function, but they could do gesture, they could do things with their hands and things like that. Okay. But also you can meet the next patient who all could have all those deficits, plus they're not able to kind of express themselves through gesture and things like that. Because I think gesture, something like that, is not very localizable to the language center, to be honest with you. So there are people who have trouble speaking. They would try to write, because sometimes the writing is preserved as well. So writing and reading, for example, is also not super localizable to one region. But again, like what I say, if a tsunami hits one side of the island, which is half of your brain, most likely a lot of things will be wiped out, and you're not able to do a lot of those things anyway.
Yeah. So what you're saying is that this is a pretty unlikely situation that you'd be able to communicate using those types of tools at the end of the day.
Yeah.
That's great. Awesome. Well, you know what? I wanted to say thank you to everyone who's watching. We've been on for about an hour. I think that's probably good for us. Once again, Tommy, thank you for joining us on Knife Skills. We've had, unfortunately, a lot of celebrities with neurological conditions, and I appreciate you bringing your expertise.
Can I say one thing, Rich?
Yeah. Oh, please. Yeah, please.
Again, thanks for having me. And like we talked about, Hailey Bieber and Bruce Willis. Again, all these are just our hypothesis based on what we see in videos, right? So, this is obviously an educated guess based on our knowledge. So, who knows exactly what they have? So, I think I just wanted to bring that out there so that it's not just like any medical diagnosis we make or we talk about. I just want to kind of stimulate people's thoughts and approach rather than that we are sure that this is definitive. Again, there's no test where I could just measure that, hey, this is this condition that they have. And obviously, we only see this as just like anyone else looking at these really short videos, but very educational.
Yeah, that's a great point. We're here to educate and to entertain. We're not providing any specific clinical advice to anyone or their families, and we try not to. We're really using their experience and condition as a launching pad to have these conversations. And our goal really is to bring our medical knowledge to the community at large, the YouTube community at large, and really share our insights onto things that are happening day to day. And we see it. There's all this stuff in the news, social media, you hear these ideas, and I realize there's important value to have a voice of trying to explain, at least from the perspective of some degree of expertise, these issues. And I appreciate Tommy once again, always an informative guest. Have a great night. All right, bye.
Thank you. Good night.